My name is Dr. Steve Sukin, 21 years as a urologist in Houston, Texas. It's my pleasure to be asked by Profound to talk about prostate cancer today and new treatments. Specifically, we'll talk in depth about the new TULSA procedure and the advantages and new opportunities for patients with prostate cancer to have another option for them. So I grew up in Billings, Montana. So somehow got here down to Texas in my training at Baylor College of Medicine, and I'm with a practice called Texas Oncology, which is a very large group in Texas, but also has grown nationally under what's called U.S. Oncology, and we're actually partners of McKesson Pharmaceuticals. So it's a pretty big company that I'm part of. But did all my training in Houston, Texas, and continue to have a practice here for many years. So what is the prostate? And you all know this very well, so we're going to move this very quickly, but it's a walnut-sized gland located under the bladder and in front of the rectum, sitting on the pelvic floor. The urethra passes directly through that prostate from the bladder to the penis, letting urine flow out of the body. And its function of the prostate, it contracts during ejaculation and distributes prostate fluid into the urethra. Prostate diseases are multiple. There's prostate cancer, which we're all worried about, and there's lower urinary tract symptoms as well, caused by enlarged prostate or BPH associated with aging. And those symptoms actually have symptoms of urgency, frequency, difficulty to go to the bathroom, where prostate cancer is a bit of a silent tumor. So what is prostate cancer but uncontrolled growth of abnormal prostate cells? And the prognosis depends significantly on the stage of the cancer, the type of the cancer. You guys are likely well aware of Gleason scores and staging, and many cancers are considered low risks. Some are more intermediate risks, or some are high risk and aggressive type cancers. Localized prostate cancer typically has no symptoms. So patients will often come to me and say, it's impossible, I have prostate cancer that you just diagnosed to me and given me this diagnosis, because I don't have any symptoms. But 1 in 8 American men will get prostate cancer during his lifetime, and without screening, they really won't have a way to know that. 288,000 estimated new cases in 2023. So there's many modalities of screening, and it's getting where patients have a lot more options in terms of screening for their prostate cancer. There's PSA tests, which we're all aware for years, and then urologists came up with free PSA. There's digital rectal exam. Traditionally, it was PSA and digital rectal exam, and those would make you get the patient to a biopsy. Normal PSA being less than 4, but more important than what your PSA is where it was and the trend of it, and its velocity or speed that it's going up with time. Nowadays, we have various other blood tests and other options to help patients decide if they should have a biopsy besides the PSA and the digital rectal exam, such as MRI scan, which is so important with our new focal therapies, and other blood tests that you may not be aware of, such as 4K score, which our practice uses a lot. So with prostate MRI really becoming very important for patients, we call it multi-parametric MRI, using special software, gives high resolution images where very specialized radiologists, we don't trust just any radiologist reading these, often using a special software called DynaCAD, can interpret the tissue density of the prostate and help us decide if there's suspicious appearance of the prostate and whether a biopsy should be offered. And then patients will have to decide and undergo a biopsy. And when that biopsy comes back cancer, then patients really want to know their options. And that's really what we're here for today. It's important to know all of your options and that there's new options. And depending on people's ages and their ability to undergo surgery and how strong their heart is and what their sexual function is and what their urinary function is, all these things come to the plate on your decision making. Do you have very slow type prostate cancer? And this top picture talks about at the top of the slide, active surveillance. which is close monitoring of patients with cancer over time. A lot of our statistics tell us that low-risk cancer patients can very safely choose active surveillance. And really about 65% of all patients we biopsy fall into where active surveillance is a very reasonable option. Active surveillance is safe, but requires a lot of monitoring and also can be extremely expensive. With monitoring, patients can have anxiety that the cancer was never treated, and will this be the year that it spreads? And I'm tired of having annual biopsies and repeat MRIs, and people have extreme fear having an MRI sometimes with claustrophobia. And all of us have extreme fear about having a biopsy. So active surveillance, which requires follow-up, is not an easy treatment. I tell my patients it's treatment like anyone else. Radiation therapy uses high energy X-rays to damage DNA of cancer cells. So it breaks the DNA, but it also damages normal cells, and it also damages tissue surrounding the prostate, such as the rectal wall, the urethra, the bladder. And so there can be rectal toxicity, certainly a high risk of erectile dysfunction, and added urinary symptoms. And long-term, these symptoms can be years from the time of treatment. I'll have patients that had radiation 15 years ago and just start bleeding in the urine, and we identify significant side effects from the radiation called radiation or irradiation cystitis. And that's very difficult to treat. And patients will be very shocked. How did I get this when my treatment was so many years ago? But we all know radiation is there to stay once you've been treated. Prostatectomies, sort of what I've been known for in my community. I was first in North Houston to provide this service over 18 years ago. I've done over 1,300 robotic cases now in my career. And for patients that have more aggressive cancer, many choose this still. But it has significant side effects and risks. And if someone has low or intermediate risk prostate cancer, it'd be great to have other options that are safe and can preserve their quality of life. And certainly we all know the risk of prostatectomy is one, just having to get through a bigger operation, having to deal with catheter, erectile dysfunction, the significant loss of quality of life if you develop incontinence, and a longer recovery time. And then we're going to talk about ablation, and there's multiple ways. Our TULSA procedure that we're going to talk below is just one modality, but we destroy tissue without surgery or radiation, and the goal is disease control with less morbidity. And we'll talk about cryotherapy, which I've done for years, HIFU, focal laser therapy, and TULSA Pro. So on that last side, I really delved into each of these, but we'll just kind of go over benefits and risks once again. But active surveillance is just monitoring. We have new genomic testing that tells patients, hey, it's pretty reasonable to do active surveillance. So markers can help us, and it can delay or potentially avoid side effects, which our patients don't want. They want it to be cancer-free, but also don't want to lose any of their quality of life. And risk can be discomfort or repeat biopsies, the anxiety of living with cancer. And then treatment typically does need eventually to occur, and it can be years away, but that anxiety to that time can be difficult. Radical prostatectomy, just says it right there, radical. That prostate is completely coming out. I'm a firm believer in radical prostatectomy for the right patients. I believe it has excellent cure. We've gotten better and better between open going to robotic modalities. We're able to preserve sexual function in most patients with nerve sparing, but certainly there is a significant risk of erectile dysfunction, and it can be, tough on a surgeon as well. I can do a surgery on a patient, think that I literally did the best nerve sparing technique I've ever done, and that patient somehow doesn't retain their erections. A lot of that has to do with their health, their blood flow in that area, their age. Patients over 65 really struggle with surgery. Even if they had good sexual function before, they don't do as well as a 48-year-old, 50-year-old that chooses surgery. Radiation therapy, it's again, probably the most popular treatment for men over 60, 65 in their treatment of their prostate cancer. Like surgery, over the years, we've gotten safer with it. However, there are real risks. And if you choose radiation therapy, patients are taking risks to damage to the local structures around the area. There's cases of urethral strictures, more difficulty voiding, prostate swelling. We talked about injury to the bladder, tissue, and rectal tissue. So these are more and more rare, but they're real and they're concerning. And also, if you look at the bottom part of the risk, 63% chance of erectile dysfunction. It's very different than the surgical mechanism. With surgery, we think it's more damage to the nerves. And with radiation, we think it's more damage to the pelvic floor vasculature. So where are we moving to? We're looking at less invasive therapies, and focal therapy has sort of been coming to us, not just over the last few years, but many years in terms of the different technologies that are out there. So focal therapy refers to several minimally invasive treatments that target only the parts of the prostate gland where the cancer is located. So that's just focally going for where the cancer is. The goal of the treatment is to ablate or destroy the tumor and a safety margin within the prostate while leaving the remainder of the gland intact. We can only do focal therapy when we know where the cancer is. So we use MRI, and oftentimes our radiologists will say, hey, the cancer is over in this area of the prostate. And when the urologist then does the biopsies, some of the times the cancer biopsy will well align with the MRI. In other words, where the cancer was found on the MRI is also just where the cancer is on the biopsy. It's not always the case, though. So focal therapy is not always an option for patients, especially when patients have multifocal biopsies, both sides of the prostate. These focal therapies are very good options for patients. But when it really does align, it's minimally invasive, and it can be an outpatient procedure. It can be repeated if necessary. It does not limit the option to have radiation therapy or surgical therapy or ablation therapies again. And RISC typically does not treat the whole prostate gland, can leave behind cancerous cells. And our main focal therapies are cryo, which is something I've done for years, HIFU, high intensity focused ultrasound, and laser. High intensity focused ultrasound has been around for many years. Took many, many years to get FDA approval and finally land in the United States. Over 15 years ago, I used to go down with educational courses, and really it could only be done in Canada and Mexico. And so there were HIFU centers in Cancun, and they were it was called American Hospital there, and patients would fly down with their doctor and have this therapy. I never became a believer of it, and I will talk about why. It's out there. It's now approved in the U.S. Many patients will get HIFU, but I think there are some concerns about this technology in terms of being able to treat the whole prostate, where each patient gets a result that is of high quality. But what it is ultrasound waves focused across the rectal wall. So you'll notice that probe is in the rectum, which is really important. You guys notice that as we move to the TULSA technology. So the focused across the rectal wall to a single point to rapidly heat and destroy targeted prostate cancer tissue. A region is targeted one point at a time. Treatments can be repeated as needed. Benefits is it's minimally invasive and it's an outpatient procedure. It's well suited to small targets in the back half of the prostate and can target diseased areas without treating the entire gland or surrounding structures. So it can be done both focal tumors and the entire prostate. Risk can be, most patients have disease in more than a small part of the prostate. Also, it really can only treat small prostates. The field that energy can come across the rectum is small. And so a lot of our patients have enlarged prostate, big prostates. And so immediately when your patients are interested in HIFU, about 2/3 of them are eliminated very quickly because that energy can't reach the other side of the prostate. You can see on that picture there, you can see the catheter coming through the urethra with that balloon, and the other side of the prostate, that would be called the anterior side of the prostate, that cannot often be reached with that focal therapy if the prostate's over the walnut-sized prostate. Walnut-sized prostates, average prostates are about 25 grams as guys get older, 35 to 45 grams. Much after 40 to 45 grams, HIFU is not a viable option unless the tumor is just on that backside on the rectal side. The whole gland HIFU is associated with moderate high rates of erectile dysfunction, urinary incontinence, and urinary symptoms. The biggest concerns I had as a clinician in bringing this technology to my practice was the HIFU energy coming across the rectal wall. That was always concerning to me. That thermal heat across the rectal wall is a big deal. And there are cases of that rectal wall getting damaged. In addition, you can see how the thermal energy is coming across that prostate in this diagram. But truly, we want to hit that anterior prostate also. You see that thermal energy is going to heat right through that urethra. And so my biggest concern in patients that I've taken care of who've had HIFU is there is a close to 60% risk of the man getting an injury to the urethra called a urethral scar. And just not something that I want my patients to have to suffer with. Cryotherapy is another therapy. I've been performing cryotherapy for almost 20 years. I've used it for patients who've had failures after previous radiation therapy. A few patients have wanted it as primary therapy, but as we all know, if you have radiation therapy and the cancer recurs, it's really a bit difficult for what your next option would be if the cancer is local and has not spread, and you're looking for a local management of that. And so cryotherapy has been out there for a long time. In fact, I went to medical school up in Boston at Tufts University, and they were a cryotherapy center of excellence. And at that time, it was really Tufts up in Boston and MD Anderson in Houston. And at that time, they used, if you can see on this diagram, these little needles that go into the prostate. Well, when I was a medical student, they weren't little needles. Each needle was the size of a Marks-a-Lot, if you will. And we put about 4 to 6 in those and freeze the prostate. And the complications were actually quite severe, with injury of the ice ball damaging the rectal wall. And at some point, the FDA shut down MD Anderson for high significant complications. Years later, some Israeli company had created new cryotherapies that use these small needles and became a useful treatment for men who'd failed radiation, but didn't want to go through surgery as their option, because surgical approach after failed radiation has immense complications of most patients being in diapers, injury to the colon, 100% lack of sexual function. And so cryotherapy has become a viable therapy where needles are placed, freezing the prostate and trying to kill the cancer. However, it has significant risks in and of itself. And that's why other therapies are exciting. But the main one is that it has a 100% chance of erectile dysfunction. I've never had a patient that didn't have erectile dysfunction after cryoablation. It has no ability by its technology to preserve the nerves. So the TULSA procedure, we're going to discuss what it is, how it works, some clinical outcomes, benefits and risks, are you a good candidate, and where to get the procedure. So my number one question is, was it invented in Tulsa? And that is not true. So a couple engineers up in New York have developed this over many, many years. And it's MRI guided, TULSA standing for transurethral ultrasound ablation. And here are the urologist slides, an ablation catheter. It looks like a common catheter going in the bladder. It's a rigid catheter, slides that catheter through the urethra in the middle of the prostate. And you can see that on this diagram here. And then you can see that it has 10 parallel ultrasound beams focused to a blade from inside the gland. And it provides directional thermal ultrasound. So similar to that HIFU, it's going to spray that heat across the prostate, but in a very, very precise manner that we can manage exactly where it goes. And then while I had concerned about the HIFU, now that is just a great example going through HIFU first, where to heat that whole prostate with HIFU, the heat had to go right through the urethra. In fact, with this, we're heating in to out. So the urethra is not getting the heat, and the catheter actually has a cooling system. Also, if you'll see below, we don't want to damage the rectal wall. We don't want that risk for our patients. And so we have a special rectal probe that goes in at the start of the case, and that rectal probe cools the prostate through the procedure. So we're preserving the rectal tissue, we're preserving the urethra. It's an outpatient procedure. It's performed in an MRI. In Houston, I developed the first hospital-based TULSA center and really had to sit down and partner up with a hospital. I had to find a hospital of high quality in my area that I work with, and that they had an ability to have one of their MRIs. Unfortunately, this Houston Methodist facility had 5 MRIs at their facility and said, hey, we don't really use this 5th one on Fridays. And so we created essentially an operating room MRI suite at the hospital. So in there, the patient's brought in there, and we have MRI guided targeting of part or all of the prostate. The temperature is measured by the MRI during the treatment, so we know the exact temperatures. It's incredible technology that we're able to know with the MRI the temperature that we're serving to the prostate. And we have real-time control using MRI thermometry. The timeline in this takes years and years, just like HIFU stories of taking years requiring treatments in other countries. This didn't just happen. This took 2 PhD students to come up with an idea. And really, as I got to sit with them a couple times, it couldn't happen until we have software updates and chips strong enough in computers to be able to put all these things together. MRI software that can see the cancer didn't exist when you see that they first started in early trials in 2003. So really, they started their first study called the TACT Pivotal Study in 2017, received FDA and Health Canada clearance in 2019. You can see how new this is. And 2020, routine clinical use. And I should have on this slide, Dr. Sukin Center in Houston, Texas in March 2022. So the FDA pivotal study was a TULSA-PRO ablation clinical trial. And in that, it was an international trial. It was about 115 patients in 13 sites. And the patients they're looking for is low to intermediate risk prostate cancer patients. So they're biopsy proven. And these are typically patients with Gleason 6 and 7 prostate cancer. It can be, in this trial, most had bilateral disease or greater than 5 positive cores. So this was not just patients that had 1 positive biopsy or a very small focus. And on the initial TAC trial, it was whole gland ablation. So we talked about focal, which we'll talk more about that here today, but this trial was whole gland with the urethral cooling. And on this initial FDA pivotal study, the primary endpoints at 1 year was side effects and PSA reduction. Secondary endpoints to 5 years, where we are now, is volume reduction of the prostate at 1 year, prostate biopsy at 1 year in all patients, multi-parametric MRI at 1 year to see what the prostate looked like, and multiple data points to look at sexual function, urinary control, quality of life parameters. And on this ablation clinical trial, so that's what TAC stands for, the PSA reduction was a median of 96% to nadir of 0.28 and sustained at 86% reduction at 4 years. And I can update that slide where it's very similar at 5 years now. What's amazing is the prostate volume significantly reduced at 1 year and a median to 91%. So imagine all these men with enlarged prostates, that their prostate shrinks, doesn't just treat the cancer, but over a 90% reduction in the size of the prostate. And a 1 year biopsy negative for any aggressive type prostate cancers of 80%. 14% of patients still had low risk prostate cancer. We put that as stage 1, which we consider not clinically significant, that it can hurt the patient. Additional cancer treatment, 13% at 3 years, which is very similar to patients who have surgery and radiation. and 16% at 4 years. Safety, 8% was serious or severe adverse events, all resolved by 1 year. No rectal injuries. Very different from other ablation treatments. If you look at the urinary control data, in the first few weeks after the case, the heat can affect the area we call the sphincter that controls your urination, and some men can have some very temporary leakage. But if you look at the 1 year data at close to 92 to 94%, and at 4 year data, close to 100% of patients are dry. That's just amazing for a urologist to even share that kind of data, and that I can have that confidence with my patients when I present this option to them. And then functional erections. And remember, this data was whole prostate treatment. And so a lot of our patients get focal treatment for this technology. And so they're going to have even better return of sexual function. But when the entire prostate's treated, and I'll show you later how we still try to preserve the nerves, at 4 years, 87% of patients can have expectation of returning of their sexual function, which is not really comparable by other technologies. Here's a real world experience from a radiologist in Germany. He had a broader patient selection, so he didn't just do whole prostates, but he did also just, we call it focal, and here it's called partial gland ablation. So 80% of this study was partially treated, 75% the radiologist spared the nerves for sexual function. And similar safety profile, 2 of the patients had to have some of the tissue of the prostate removed after the procedure, and 1 patient had to wear a pad at night, but 100% of this doctor's experience reported maintaining their sexual function. 73% had negative MRIs and no PSA failures. I like the diagrams over here. They're really interesting to show you all the difference between whole gland and partial. So we're going to just look at the 2 first rows. And very interestingly, you'll see the whole gland. The top slide depicts the urologist using the software during the Tulsa procedure. That orange line is drawing out the prostate. We actually draw it out with the software where the prostate is. The second slide is the live heat. That thermal heat, when it turns orange, it depicts a temperature of above 55 to 58 degrees centigrade to heat the prostate. The third slide that is yellow is a pixel depiction by the MRI and the software that everywhere in that prostate was treated. So you can see there that the whole prostate was treated. And then when you go to the final slide on the bottom, this is a repeat MRI. And if you compare, it's going to be helpful when I show you the partial next. But really what you see in the slides are small, is that at the top where the orange is drawn, all that is prostate tissue. And when you go to the bottom slide, what it depicts is there's no live prostate tissue there. To show that in a better way, we're going to go to the second row where it says partial. So now you can see that the urologist, he initially drew out the whole prostate, but he only turned on the heat, as you can see, from approximately going from, call it 5 p.m., go clockwise to 1 p.m. That's the only place he allowed the treatment to treat. He left alone an area that had no cancer and the nerve that lies lateral to the prostate there to help preserve sexual function for the patient. And you can see on the second and third slides down on that middle row where it's not treated. You'll see the blue that's not treated on the second one, and clearly the pixels on the MRI are showing no treatment there. And then if you really look at the bottom slide, that is amazing to me. You can really see full tissue on the top one, and you can see live tissue. There's still live tissue where the urologist or radiologist here intended not to treat. So he absolutely preserved all that live tissue. That's how accurate we are able to 3-dimensionally heat that prostate. This is another radiologist, I believe up in Finland, who just showed here that this is also a safe treatment for patients who've had radiation therapy and the cancer has recurred. And if you look, they're going to call it salvage TULSA. That we steal that from when we take prostates out after radiation. The risks are so high, we call it salvage prostatectomy. So we're calling it salvage TULSA. And here's a post-radiation patient, had recurrent prostate cancer, treated one side of the prostate, the side with the cancer. And then you can see the result in the middle bottom slide, where that cancer that was intended to be treated is fully treated. A current trial that is underway now is called the CAPTAIN trial. And this is a really important trial. The biggest thing in any new technology is it takes years to show it's safe and effective. It's hard to have a new technology. It's tough to be the new guy on the block because we have to compare with treatments that have been shown to work. Surgery and radiation have 10, 15-year data. That's tough to compare. And I really am proud that Profound has decided with their technology that they're going to create a trial to compare themselves right up against the gold standard treatment of a prostatectomy. So this is a trial where patients are it's an undergoing trial, currently being randomized into having TULSA versus radical prostatectomy with primary endpoints for safety and efficacy. Secondary endpoints will be survival, how well the percentage of recurrences, follow-up MRIs, complications, erectile dysfunction, and many data points to look for quality of life. I can already give you some early preliminary results, and it's what you would expect at early 1 to 3 year data. We're already able to report that it's what you think. They're fairly equal in cure rates. They both have some recurrences. Prostatectomy is not perfect, as you know. Radiation is not perfect. But we also can see quality of life where close to 95% of patients are continent. Most patients are preserving their sexual function, having the ablation option. So the patient journey for TULSA-PRO, some patients' journeys, it's tough because they may never be presented to this. So this is why we're so excited to get to present to you today. But I would say the biggest thing in the journey is your urologist may not ever present this option. But certainly we get disease detection, diagnosis and staging, seeing a urologist, screening for TULSA. In order to have a TULSA procedure, an MRI prostate must be done and a CT scan must be done to evaluate the prostate to make sure the patient is a proper candidate. You have to have proper medical clearance, preoperative visit with nursing, prior to surgery. Once the patient's chosen to have TULSA, we go over the various risks and what their experience is going to be like, and we get them ready for their treatment day. So the biggest thing about getting ready for a TULSA is the bowel prep. We need to have the bowel clean so that we have excellent visualization when we have the MRI performed during the case. And so we get my patients undergo general anesthesia. I meet them in the MRI area. So I don't meet them in the surgery area, I meet them in the radiology department. And then the anesthesiologist meets them. We have them walk into the MRI machine like any other patient. They lay down on the MRI table, and then they're put to sleep under general anesthesia. So once they're under general anesthesia, it takes us about 20 minutes or so to sort of get them set up where we put the device inserted into the urethra, the rectal probe in, secured in the MRI, make sure they're all padded because we're going to push them into the MRI machine and they're going to be there for anywhere between 2.5 and 4 hours to get the procedure done. So once they're in the MRI machine, they're in there by themselves. Anesthesiologist is next to me the whole case for safety. the patient has to be, for this technology, the patient has to be paralyzed the whole time. So we use a anesthetic that paralyzes the patient. If the patient moves 1 millimeter, that could affect our aiming and change the whole procedure. So we don't let them move at all. It's very important. Even opening doors can shake the room a little bit, and we've had to learn how to restart the case. And then we start working on the treatment. So just kind of going through preparation here. Outside the MRI, we're just getting the patient ready. Once they're in the room, we do precise treatment planning. So I've already planned with the patient before the patient goes to, in my preoperative consultations, am I just doing focal or whole prostate? That's a decision that the patient and physician make well ahead of the day of the procedure. And so I already know my plan when I get there. And, that really makes a difference. You would never make that decision. And you certainly know, does the patient want the entire prostate treated, just a certain area? What is the performance of their sexual function? What's their urinary function? Do they have a really enlarged prostate and want this prostate to be shrunk? Those things are all really, really important. So on the third slide, that little device you're seeing in the light blue, that's actually depicts the catheter going in the urethra, and then it is held on with a robotic arm that's adjustable from outside the room and can help me precisely look at the prostate gland when we're in there. So once the patient's put to sleep in the MRI, we go through various planning where initially I have to get the catheter all in the correct place. Those 10 devices, those 10 heating zones have to be within the prostate area. They can't be too many of them in the bladder or too many in the urethra. They have to be across the prostate. So that takes some planning. And then once we do that, we three-dimensionally bring up the prostate and make a plan exactly where we're going to treat. And then once we get that, we actively treat and monitor. And when we finish, we do that last MRI that we had shown when we did a couple slides back, where we confirm that we've treated the whole prostate. So this is sort of the treatment workflow. The patient's sedated, devices are placed. The urologist or radiologist describes the ablation zone in the 3 dimensions with this MRI. That's what this is depicting in the middle slide with the orange drawing. So that's ranging from the lesion to the targeted to the whole gland. So here we have the whole prostate is treated. And then the next slide, we'll start looking at ablation. So we're actually, if you're able to, there's a bar on the second large picture on the right. So this is actually a slide of the ablation. These very top 2 views, when you do an MRI of a prostate, we don't just have one view across the prostate where we're treating. Think about the prostate as a hot dog, and you slice that hot dog every 5 millimeters. So a bigger hot dog's going to have more slices, but we're able to have 10 slices, so every 5 millimeters. And we made darn sure before we brought the patient to the case that we know our 10 is going to make it from the base of the prostate or the bladder side all the way to the apex. So we are sure that we're going to be able to treat the whole prostate. And then what the video would show is the black line here is on the bottom slides. That's where the urologist has drawn out the prostate gland. And then once we've decided, we press on. And the heat goes from that urethra. That's the black center of the prostate on those drawings. It looks like donuts, but it starts from the black center and it thermally heats in a direction. So in this case, think of 330 to 4. That's where they started. And we've now heated. And after the software decides that we've fully treated in one direction, it continues to treat, in this case, clockwise around the prostate. So it started maybe 45 minutes ago, and it's come around all the way to the 1 o'clock position. And if we kept watching it, it would come all the way around full circle. And when I treat my patients, we go full circle, and where the cancer is, we'll treat a second time. But what you get is that thermal temperature is given real data to the doctor. And so you're seeing all those pixels there that look orange and yellow, which tells you a complete treatment's occurring. If there's any pixels that we don't see treated, we can go back to that area and further try to fill that in. What you notice here is you don't see any heat outside that prostate. You really don't. So you just see it going where it's drawn. This is really different than HIFU, where they're really just trying to spray the heat across the prostate to what they can extend it. Here, we are absolutely defining where we want it treated, and that's where it treats. And really, that's been proven with their data and really helped them get their FDA approval. The other thing you notice is in this case, the nerves were spared. The nerves live at the 5 and 7 o'clock position just outside the prostate. And you can see here, no heat went towards those nerves. And that's why we're able to predictably salvage the nerves. What to expect after the procedure? Most of my patients, I give them a course of antibiotics and often medicine for bladder spasms. I don't give any pain medicine. I haven't had any patients request any pain medicine. When we finish the procedure, we put a catheter in. The catheter stays in anywhere between 1 week and 2 weeks, depending on the treatment that was done. If the treatment was focal therapy, I leave it in for 7 days. If it was a whole prostate, I usually do 10 days. If it was enlarged prostate, we didn't really mention that too much, but we use this just for enlarged prostate as well, or men with it who have really big prostates with prostate cancer. We will leave the catheter in for a couple weeks. Procedure success, the physician's assessment following the procedure will determine the success of the TULSA procedure. So to me, that means at the end of every procedure, we review the case. It's downloaded into the company for Profound. It's transparent for my patient. They can watch their case. We can put it in a USB port. And we can really show them the before and after MRI that we did what we said we were going to do. And if there's any challenging areas that didn't get treated as much as we hoped for in that treatment, we'd be able to show them that specifically. Follow-up from the TULSA procedure will be determined by the treating physician's assessment. In my practice, I have their catheter out, as we discussed. It depends on their treatment. And then I like to see them a couple weeks after the catheter is removed. After that, similar to prostatectomy or radiation therapy, I see them every 3 to 6 months, depending on how they're recovering. And then at 1 year, we're getting a PSA and an MRI. Recovery time, as observed during the pivotal study above, patient typically return to their daily activities within a couple of days following the procedure, and then back to baseline urinary bowel quality of life within 3 months. It's truly amazing that the patients do have some bladder spasms or the need to pee the first night from sort of the thermal therapy to the bladder. But that typically is resolved the first morning after the procedure. And most of my patients say in 2 days, they have absolutely no pain at all. Sure, they have a catheter in. No one's going to really enjoy having that in. But recovery is exceptional with the TULSA procedure. We haven't had any outliers with this in my experience at this point. Everyone's had similar experiences of feeling like themselves in a couple days. Are you a candidate for the TULSA procedure? Men have to be eligible for an MRI, healthy enough for general anesthesia. I've had disappointed patients because if patients have large cysts or many calcifications of the prostate, it can potentially interfere with the heat coming from the urethra towards the cancer. So some prostates, different than kidney stones, some prostates just for natural reasons have internal calcifications. And if it's a large calcification and it's in the direction of where the cancer was found on the biopsy, the heat may reflect right back towards the catheter and may not be able to go through a stone in order to successfully treat the tissue. I would add that I've had a few patients have had hip replacements, and large metal hip replacements can also sometimes affect the quality of seeing the prostate gland with the MRI. It's unbelievable how close a hip prostheses to the pelvis, but it can cause what we call artifact, or making the visualization difficult to view the prostate, where it would be hard for us to be able to properly draw out the prostate in our planning. I think the best part of the TULSA procedure is our patient's experience and their quick return of quality of life and reaching their goals. The goals for all of us, I've always said in my career, what am I looking for as a urologist in my career that I want to present to my patients? You know, no one wants to give the bad news of prostate cancer, but what we do want to give is treatments that can have minimal side effects, and give this opportunity to our patients where they have a chance to have the cancer cured, preserve their sexual function, preserve their urinary control, preserve their quality of life, and move on with their life as if it never happened. So that's our goal, and my career goal for my patients. So of course, there's a tulsaprocedure.com, and you can find centers close to you. We don't think a flight from New Mexico to Houston is very bad. So if you ever need to come see us, we'd be happy to make that happen for you. But very excited about being a urologist that's joined in on this technology. I feel like I've been an early discoverer of this, and very excited as my practice has grown with patients excited to have this done for them.